Hi, welcome to this short talk from the ACIL Clinical Placement Series on discharge summaries. My name is Matthew Links and I'm the Discipline Lead for Medicine Placements at Bond University and a medical oncologist here in the land of the Kombumerri people on the Gold Coast. Writing a good discharge summary is a key clinical skill and something you need to be intern ready. This short guide gives you some tips about what a good discharge summary looks like. The advice given is independent of what system you use or whether it's paper or electronic. It's all about quality. Healthcare communication is orientated towards action, and three critical tools to promote this are a summary statement or a formulation, a problem list and an action list, and there are associated videos in this series about each of the skills. This video is about putting it all together. Writing a good discharge summary is a skill honed by deliberative practice and feedback, but it starts with understanding what quality looks like. It's very likely that generative AI is going to make the process of generating a summary simpler and quicker, but the priority of determining whether it's of any quality is going to be even more important. So there are 7 quality lenses that you can use to characterize a good discharge summary. Is the content both comprehensive and concise? The second is clarity, keeping the language as simple as possible. Third is being person-centered, which means taking the point of view of both the patient and the recipient of the summary in this situation. Being holistic is the next lens. How you summarize says a lot about your ability to see all the aspects of the patient's health. Next, adopting a team perspective. A poor discharge summary will take a medical focus and ignore the contribution of other team members. You don't want to do that. Next, being quality and safety focused helps prevent errors and deliver quality care. And finally, one of the areas the health system doesn't do well is cultural safety. So we'd recommend a quick cultural safety review on this area. Now we'll go through each of these issues in a little more detail. National standards have identified 8 components of what comprehensive looks like for a discharge summary, and they're pretty self-explanatory. Medications are a focus because they're a frequent source of errors. Documenting medications on discharge and reasons for change are 2 components. Now note that the reason for admission is not the same as the history of the presenting illness. Summarising treatment in hospital needs as much detail as is required to pick up the patient's care, but not more. Discharge summaries and a list of diagnoses are self-explanatory. The results of key investigation doesn't mean every blood count they had in hospital. It means summarising what was important. And identifying pending results is a safety issue, as we know that results can be missed, and this can be an important quality and safety issue. Now we all get hundreds of documents to read, so being concise reduces the cognitive load. So the key step is to ask the question, does this need to be included? Using dot points is a way of reducing unnecessary text. Copying and pasting can be okay, but you need to edit. Copying and pasting large blocks of irrelevant information is poor practice. Summarising and using attachments to provide details for those who want them is another strategy that keeps things concise but is flexible. Keeping it simple is not so easy, as we all use technical language to summarise information, and that's a good thing. But remember, patients read their discharges. So if you can express it so a patient would understand, all the better. You can also consider translating key terms to help patients read their own discharge. Now don't assume all acronyms are universal. People probably know what a STEMI is, but you can't assume a non-oncologist knows that TNBC is triple-negative breast cancer. Being person-centered is a key value, so try and adopt the point of view of the patient. What would they want you to prioritise? What would confuse or upset them? And a good problem list deals with this by identifying and prioritising patient priorities. You should also consider patient fact-checking. Check with the patient whether it's true they have a history of Parkinson's disease, or was that tremor mislabeled? And simple language helps. And with any communication, you need to adopt the point of view of the recipient. After all, the communication is for them. What do they need to know? What would make their life easier? Try reducing the cognitive load on the GP. A key strategy is to utilise GP skills and processes. So the patient needs support after their cancer diagnosis. Well, the GP may be looking after the carers as well. They can utilise their knowledge of the family. The GP generates a patient care plan. Reviewing this would be a good strategy for deciding whether you need to worry about the cholesterol after palliative diagnosis. Understand and building on the strengths of the GP and what they can offer is a good practice. Being holistic is another key value. You don't want to be the kind of doctor that ignores the psychological, social, or planetary health aspects of your patient's care. So ask yourself, do the problem list and actions reflect the whole patient? Have you addressed distress and coping, barriers to accessing care, the caring and support network, for example? Carer stress is a very important problem for the GP to know about, but how often is it documented? Have you thought about the patient's communications needs? Do they have a poor understanding of the advice given them? That's something the GP would definitely want to know. And are there any ethical dilemmas or cultural safety issues to highlight? The next lens is a team approach. And to be able to adopt this, you need to first understand the hospital stay from a whole of team approach. Did they see a dietitian? What did they say? Are they going to follow them up? Next, you need to ask yourself, does the discharge summary reflect this? You don't want to be the sort of doctor who forgets to organise follow-up with a dietitian. Does the treatment in hospital include all the other team members that were involved? And is the discharge planning inclusive? A key aspect is the arrangement of follow-up or pending results from other referrals. Handovers like a discharge summary are key risks for errors, and they're also key enablers of quality care. So ask yourself, what are the potential quality and safety issues? What could possibly go wrong? And how could I prevent it? So an example might be that the follow-up referral might get lost, but the patient's quite on top of things, and you've asked them to check if they haven't heard back in a week. This is an example of safety netting. Now, selecting issues as a problem or an action should be driven by the impact on quality and safety. Pick out those things that are quality and safety issues to prioritise. And the summary has a key role in flagging these issues. And finally, cultural safety is an area the health system needs to improve. So it's worth doing a cultural safety review. Is there a cultural safety issue? And if so, identify, name it. Did you learn anything during the admission that would perhaps help the GP? You might have discovered the patient comes from a community that's had a bad experience of the health system and this is impacting on their care. The GP would like to know that. What you did in hospital and discharge around cultural safety should be documented, and make sure you acknowledge the contribution of team members like Indigenous liaison officers. So to summarise, writing a good discharge summary is a skill you should learn and practice. Balancing being concise and comprehensive is key. A good formulation and problem list is the key to starting, and a good action list the key to wrapping things up. A critical process is reviewing and editing with a critical eye. Now just imagine you are the GP or you're the patient, and then adopt lenses of being person-centred, holistic, team-based, quality-focused, and culturally safe. Finally, get feedback and improve. So I hope you found something useful in this talk and some takeaway skills to make good quality discharge summaries. If you're a Bond student, I encourage you to look up the learning and practice pages on iLearn and invite everyone to look up the other videos in this Vimeo or YouTube series. Please leave a comment or a request for further resources, and I've posted some other resources you might find useful. Good luck, and may your summaries be succinct.